Thank you all so much for joining us for today's program. Do I Need to Be an Addicts Expert? Engaging and supporting people with our speakers, Tanagra, Melgarejo, and Pereira. Please listen carefully to the following instructions. This webinar will run from 12 to 1:30 p.m. All participants will be muted throughout the program. Feel free to add your questions and comments in the chat. You will also be instructed whenever there's going to be a Q&A session. And of course, we always host a Q&A session for the last 15 minutes of the program. There will be a code given at the end of this webinar. Please do not leave this room without a code. All participants need to enter this code in the evaluation form. The evaluation form will be given at the end of this webinar in the chat, and is also linked in the emails that you received today and yesterday. Please note that this webinar is also being recorded and will be posted to the NASW Online CE Institute. Thank you all so much for joining us today, and I will pass it over to Sarah.
Thank you so much, Chris Belli. If folks, that would be terrific. Thank you. Thanks again, Chris Belli. I'm Sarah Merrifield, and I'm the Senior Program Officer at RIZE. For those of you who were unable to join us at the last session, I'd love to share with you just a little bit about RIZE and this terrific partnership. So RIZE Massachusetts Foundation is the only public-private partnership that is solely dedicated to funding and creating solutions to end the overdose crisis. We are guided by those with lived experience, and we're unafraid of new ideas. We build networks and design programs just like this one to support our community partners who use novel approaches to prevent overdose. Next slide. We know that social workers are absolutely critical for ending the overdose crisis. We are thrilled to announce this really groundbreaking partnership between the National Harm Reduction Coalition, RIZE, and the National Association of Social Workers, the Massachusetts chapter. We put this together to really expand knowledge and create a space for dialogue and learning, all with the goal of providing enhanced care for those with opioid use disorder. This series has been created to really provide information about harm reduction practices and the barriers that stigma can present, including the limitations that it can create when you're developing meaningful relationships with your clients. Next slide. So as you can see, we had terrific feedback from the last session, and I won't read all of these wonderful takeaways to you today, but I'll say this. No matter where people were in their experience, whether they're new to harm reduction or had many years of doing this work, it was clear that everyone walked away with something really important to improve their practice after the last session. And we have Tanagra and Joe to thank for that, and I'm absolutely sure that you'll have the same experience this time. So without further ado, I'll turn it over to Joe and Tanagra, who will introduce themselves, and we'll begin this session. Thank you so much for being here.
Thank you, Sarah. Thank you, Chris Belli, and everyone who's supported us in making this happen. I am thrilled to be here today with all of you. I see some folks here that I recognize from the last session that we held during the symposium, which was amazing. And we are grateful to be in community with you to have these conversations about, do I need to be an addictions expert? And remember that question, because we're going to be coming back to it at some point throughout this training. Engaging and supporting people who use drugs. We're planning on looking at the intersection of stigma, substance use, and trauma. My name is Tanagra Melgarejo Pulido. Hola, buenas tardes, saludos. Hi, everyone. I'm part of the National Harm Reduction Coalition. I've been with NHRC for about almost 5.5 years. But I've been in love with harm reduction for many years before that. I fell in love with harm reduction in the mid-90s. And when I used to work in Holyoke, Massachusetts, and harm reduction found me and never left me. And I'm really grateful that it did find me, because it's changed my life. It's made me see myself and the way that I want to do my work and the way that I want to build relationships with people, and given me the opportunity to really do that in a way that honors and centers people as humanity, imperfections, and power, and messiness, and all of those things that are part of the world that we are in. So I'm really excited for the opportunity to work with Joe again today. This is our second ride in a different in the amusement park, as I say. And so I'm gonna let Joe introduce himself in a second. I'll just say that I'm also a social worker, and harm reduction has also really enriched my practice as a social worker, and really has opened doors for me to view the work that I do as a social worker and how I show up as a social worker differently in a much enriching and I would say profound and life transforming way. So I'm going to pass it over to you, Joe.
Thank you, Tanagra. It's great to be here with you again, and thank the RIZE and NASW for this opportunity. And just to kind of let you know, I'm going to give you the answer to the question, do I need to be an addictions expert? I'm going to tell you no. Hopefully you'll agree by the end of this training. So what I have been, I first got introduced to sort of working with people around substance use issues back in the late 80s in a work-study job at a alcohol treatment agency for people who got arrested for driving while intoxicated. I was asked to complete a questionnaire as part of their evaluation. But in every sort of setting that I've been in, and I've been in a lot, both in the court system, the correctional system, EAPs, hospital settings, community mental health, residential settings, and now in private practice, I'm always have dealt with a number of individuals with substance use issues. So I don't think you can not have a practice wherever you are and not encounter people who may be struggling with these issues. So to quickly go over the table of contents. So what we're going to try to cover today is just a quick overview of harm reduction and drug-related stigma, and then talk about what stigmatizing language is and how shifting language can help us both in terms of empowering the individuals that we're working with, but also to help us engage with them. And then what are the questions or what are the approaches to work with if you're sitting with somebody or interacting with somebody who may have a substance use issue, and then specific action steps for practice promoting compassionate and non-judgmental interaction. So we're hoping to cover that. What we're going to be doing is, I know there's a lot of people here, but we want to encourage some interaction through the chat. And actually, the first question I'd like to ask people, and again, perhaps they can provide their answers to this question, is why do people use drugs? Next slide. And when we are thinking about working with these individuals, I think it's important to understand motivations. So why do people decide to use drugs? So if people could sort of put their answers in the chat: to alleviate pain, pain reduction, stress as a coping mechanism, coping with trauma, many reasons, yes, escape, environmental neighborhoods, a genetic predisposition to numb themselves, dealing with negative emotions, self-shame, to have fun. Yes, that's very important. People use drugs because it feels good, regardless of sort of motivation. Escape trauma, friends or family are using to numb themselves, so we're getting some patterns there. Recreation, absolutely. Genetics, do whatever peers are doing to reduce psychological pain, to feel less anxious, peer pressure. All right, so great feedback there. And so the next question, again, important, is because I think by asking this question, also gives us insight into how we as social workers can be helpful. So why don't people stop using drugs? Lack of proper coping skills, lost ability to manage emotional states, access to treatment. Drugs change the way the brain works, yes. Lack of support, no support system. Untreated mental illness, fear, lack of motivation, difficulty finding replacement for relief, dependence, yes, lack of other coping strategies, physical pain, again, lack of support is showing up, fragmented treatment programs, absolutely. And I'm going to touch upon that. It hurts physically to stop using, lack of services, great, yes. So those are important things to keep in mind as we are dealing with this issue. I'm now going to turn it back to Tanagra.
Thank you, Joe. And I appreciate all the responses in the chat box that were very, they were very diverse, because people have many different reasons why they use drugs or they don't stop using drugs. But one thing that those have in common is that harm reduction is the space that we can create to have conversations with people where they feel safe, not only disclosing their use, but also disclosing the benefits that their use provides for them, as well as the challenges that they encounter in terms of their relationship to substances, right? I saw something there, people don't stop because they're not ready or because they don't want to, right? And harm reduction allows us for that possibility. There's no expectation that people have to quit or desire to quit to be treated like people, to be seen as human beings. So harm reduction is an approach, right? It gives us the tools. It gives us, I love to eat. And so if you've been around me, you know that I always make reference to this. Harm reduction gives you a buffet of options, a smorgasbord of options, things that you can think through with people, and they can choose to try those out. Right? They may show up to the buffet and say, hey, that salad, I've never seen it. Those ingredients seem funky together. Let me see and try it. I may not like it, but I don't know. And the person tries it and it's like, okay, I'm converted. And for us other folks is, you know what? Like, no, I don't like pecans and blue cheese together. So I'm not even going to go for that salad. I'm going to try something else. Or I'm going to not try anything. Buffets are really overwhelming. I need a moment to pause and figure out what I want. And so in terms of that smorgasbord of options that we have, the spectrum of strategies that we can use to reduce these negative consequences that have to do with drug use or sex work or any other behaviors that folks may be dealing or navigating, we have the opportunity to have conversations with people about safer techniques, right? And so safer techniques are things that people already do that they may be engaging in, or that their friends and other people around them may be engaging in. Some of them may not know all the safer techniques. So this is the moment of asking some of those questions about what are some of the things that you do to keep yourself safe. So if you can think of one safer technique that, harm reduction provides people, if you can type in the chat box what that would be, I would greatly appreciate it. What would be one safer technique that we can offer people from a harm reduction approach? Naloxone, Gia, yes. MAT, Sam, absolutely. Not use alone, use with a friend. Thank you, Naomi. Amy Lynn, yes. Clean, accessible supplies, yeah. Not to share equipment, syringes, safe consumption sites, and yes, safe use sites. And we have one in New York. The first safe consumption site has been open in operation. And if you haven't watched the Joan Oliver episode on harm reduction, I highly encourage you to watch it. Maybe we can share that link because it speaks to that and it shows that site. So if you're curious about it, that is a good place to sort of explore it. So safer techniques, all of those are great safer techniques. Working from a trauma-informed lens is also a safer technique. And then we have managed use and abstinence. Those are other spaces for conversation as well with people. There's people that may not be ready to quit yet, but are ready to rethink their relationship to a particular substance, right? And so thinking about managed use and having a conversation about what that would look like for them is a great space. I may not be willing to quit yet, but I'm willing to cut down, right? Or I'm willing to think about the route of administration that I'm using and consider using a different one that feels safer to me. And then there's abstinence, right? Which is part of the harm reduction continuum. There is this mythology out there in the world that tells people that harm reductionists, we don't believe in abstinence. We 100% believe in abstinence. There's many harm reductionists that use drugs and identify as people who use drugs with past lived experience, meaning that they are in sobriety or in abstinence at the moment. And also, we know for a fact, and most of you here who are in the behavioral health and behavioral world and think about these things know that if you force something upon someone, it's very highly likely that we won't be successful in maintaining that change, right? Because if it doesn't come from me, if I'm not choosing it, the motivation behind keeping it going can really not be there, right? And so abstinence has to be a choice for people. That I want something doesn't make it any easier. And we all know, because of the things that you've said here, the barriers that people experience, that getting to abstinence and staying in abstinence can be really challenging. And so if I don't have the supports that I need, and that is not coming from me, that can make it really, really hard. So harm reduction believes in abstinence if it's a choice for people, if people are making that conscious choice and it's coming from them and that's what they want. And we will walk alongside that path with them, and we do. Harm reduction is
Tanagra,
yes,
actually,
yes.
one quick thing about the abstinence, and I think when we think about people who are not addictions experts, is that they focus on abstinence, and maybe that's what they're most comfortable with. But kind of again, as Tanagra talked about, that this is a continuum, and being able to have a dialogue with a client or a person that you're dealing with around managed use or safer techniques.
Yeah.
Thank you.
Thank you, Joe. It's a good reminder. Thank you, Joe, that we need to meet people where they're at, as Dan Big used to say, and other harm reductionists, and also acknowledge that any positive change is what the person decides is change for them. So it doesn't matter what it is. If it's any positive change for that person, that's what we want to sort of hone in. And so following the person's lead, walking at the speed of trust in terms of what the participant feels or the client is trust or the patient, super important here. Thank you for that reminder, Joe. And we also want to think about harm reduction as a movement, right? It's a way of viewing the world, of viewing ourselves, of viewing the people that we work with differently. And so harm reduction believes that public health equals social justice, that racism, stigma, criminalization, and I will add here, misogyny, trans and homophobia, poverty are all the real true reasons that people experience harms. That there's no way that we can end inequality and oppression if we're not working from a framework that fosters health and liberation. And ultimately, the only way to do that is by centering and really following the lead and believing in the leadership of those that have been most impacted, who are people who use drugs in this case. And so if it's good for people who use drugs, most likely it will be good for all of us. And so harm reduction is asking us also to really think about the ways the systems that we're in impact people that we work with and also impact us, right? Because we're also, experiencing the holding space for people and creating safe spaces for people when they're coming from experiences that have taken that away from them. So it's asking us to really be mindful of what it means to work with people who use drugs when there's such a hostile environment towards them, outside of the systems of care that we may be engaging in. And it's also asking us, this is another important piece, to understand cultures and contexts, right? Harm reduction is not a one size fits all. It believes that we are working with that person and what that person thinks is best for them at that moment. And so thinking about what am I really listening? Am I really listening? And what is that I'm really hearing this person tell me? Or am I telling them what I think is best for them, right? So it's asking us to take a step back and be in that active listening space and hold ourselves in the discomfort that this person may be telling us something that is uncomfortable, as Joe was saying, for us to hear, and work through that. It is also asking us to consider accessibility. Sometimes we may have recommendations for people that are unrealistic because there's no accessibility for those, right? Because they're not in a language that the person feels comfortable speaking, or because they don't recognize that person's gender identity or gender expression, or because it's asking them to leave behind their family and the folks that they care for, and there's no support systems for that. So I can't leave if I'm a caretaker, I can't do that, right? I can go into an inpatient program because then that means that I risk having other systems be involved and judge me and stigmatize me and shame me, right? So we want to make sure that we're capturing that person's lived experience through this process, and that we start asking questions from a place, as my colleague Emma Roberts says, from a place of caring curiosity, right? I'm asking the questions because I want to understand, and I'm asking them from a place of empathy, right? I want to dive deeper with you at your pace. At the same time, right? I want to dive deeper and understand from a place of empathy and care, and not because I want to be punitive and I don't want to shame you or force you into something. And now I'm gonna pass it to Joe, who's gonna share my favorite ever in the world model with you all.
Yes, thank you. Thanks, Tanagra. I think about I think one of the keys that you'll probably hear, keywords that you'll be hearing throughout this is this notion of curiosity and being curious. So it's going to be repeated and repeated and repeated, I think, to a certain extent. But to that point of carrying curiosity, and we'll touch upon this a little bit when Tanagra talks about stigmatization, and is our own sort of feelings about people who may use substances. And I'm going to talk a little bit later about an encounter that I had with a client who had an encounter with another clinician where I think that person's countertransference or their reactions to people using drugs got in the way of really providing some help. So along with Tanagra, so I think I said last time, motivational interviewing and harm reduction really sort of changed or influenced how I approach people with who may struggle with substance use issues. I think drug setting model is just a really nice way of approaching this. And again, thinking about it for those of you who may not feel comfortable working with people with addictions or substance use issues, is I think this is just a really nice way of approaching this. And this model was actually given a lot of relevance by Norman Zinberg, who was a psychiatrist at Cambridge Hospital. And back in the 70s, he was working with returning veterans from Vietnam. And many of them became addicted to heroin and opium while in Vietnam. But the vast majority of them stopped when they returned to the United States. And so one of the questions is, why was that happening? And so he sort of, I think this came, these concepts came before him, but he sort of really elaborated on them. And so each of these factors influences each other. And so it's really helpful to think about sort of this when you're working. So obviously the drug itself and what the person is using is going to influence sort of your approach, but not only the specific drug, but how they may be using it. Are they snorting it? Are they using it orally, IV, smoking? That's going to all impact on sort of sometimes the severity of the addiction, but also the level of risk that the person is experiencing. You know, when we think about the other epidemic that occurred a number of years ago, the crack cocaine epidemic, what made it so attractive was how it was sort of made much more easier. Prior to crack cocaine, people had to freebase, which was much more complicated process. Crack cocaine was ready-made for people. So it made it much more accessible to use a quicker high by smoking it versus snorting and that sort of thing. So you have to think about this in working with people. The other thing I would say, and all of you probably have this experience, that you may be working with people with who use multiple drugs. So my favorite question to ask is the desert island question, meaning what would be their drug that they would take to a desert island and want to use if they didn't have any other restrictions. I find that sometimes can be really a good highlight to what people may be dealing with. So that's a good question. And then, so just to acknowledge that on this slide, we have the top, it says drug setting model, but in the circle, it's risk setting. And as Tanagra pointed out, we're also kind of talking about any behavior that potentially causes a risk and how is that person engaging in that behavior. The set refers to the mindset of the person. I know a number of you addressed the, I think, the issue of trauma. So a person with a history of trauma, and many of you may be familiar with this, especially among women a number of years ago, sort of the issue of how many women have trauma backgrounds who also use substances. It is astounding, although again, not surprising. So that's part of the set aspect of it. And then the setting is sort of what's the person's environment. And again, as social workers, we're supposed to pay attention to this. So I think it really goes in line to what we as social workers have been trained. But is the person, again, a number of you have already referred to this in the chat, is the person using by themselves, or is the person using with others? And how are they using with others? Is somebody available to help them if they were to overdose? I think things obviously have changed, but when I first started sort of working in this field in addictions, many women were often introduced by especially in heterosexual couples, by their partner. And it was a way of staying in relationship with them. So they were seeking relationship, and as a way of connecting, they would start to use substances as a way of doing that. Obviously, I think there are other reasons, but that's also something to keep in mind. And then when we think about the effects of prejudice and discrimination and racism as how people then may use, and in the setting, that would be under the setting, and that obviously impacts on a person's sort of what they're experiencing in terms of mental health, and then the drugs that they may choose, and then people from the LGBTQ plus community, the higher rates of stigmatization because of that, and so their inclination to use substances. So again, I just think it's a really helpful model to approach this issue.
Yeah, Joe, I just wanted to name that a couple of years ago, we had the opportunity to carry out a short study that was looking at Black and Latino men that identified as men that had sex with men alongside the Counter Narrative Project and BEAM in terms of what their use looked like and why, right? And a lot of the reasons that folks that we interviewed raised was, as someone who doesn't feel safe in my community identifying as a man that loves other men or is attracted to other men or wants to have sex with other men, drug use or substances, particularly methamphetamine, and the party and play scene is really big. And for them, it was a way of connecting to self and finding a connection to others that felt less threatening, right? It was a way to to enjoy the experience and sort of disconnect from that shame and stigma. And also something around set and setting that we also realize is a lot of the times when we go into therapy, therapists will ask us about our drug use. That's the only thing that they care about. And I want you to ask me about what are the challenges receiving care that responds to my needs? What are the challenges that I experience, in terms of finding safe housing or employment or building relationships with family? Those are things that are really important to me, but seldom get asked when I enter a therapeutic relationship as soon as I disclose my drug use. And to me, that was really enlightening, right? Because it's a reminder that drug set setting is a model that is asking us to look at the whole person, right? Not in the way that we have been taught, which is very much siloed. And so, yeah, when you said that, it reminded me of
Great.
that. So
thank you. So, and actually that's a nice segue to Tanagra's comments to the next slide here, this illustration. So it's two people, white man and a person of color sort of running a race, but a lot more obstacles for that person of color, but it's kind of like, what's your problem? It's the same distance. So this points out the obstacles that I think are not recognized by the power structure at hand about what people have to deal with. And already individuals from marginalized communities, sort of the obstacles in place, and then they have to deal not only with those, but then, and this segues into Tanagra's discussion about stigma around their drug use, and that being an added obstacle.
Thank you, Jack. So I think that maybe we want to start asking folks to reflect on these questions, and hopefully, we can see your responses in the chat box. But I want to ask you, what is, in your mind, your opinion, or what you heard from participants, what is stigmatizing language, and how is it a barrier to our work with clients, right? When it shows up and when it's present, it doesn't have to be in our relationship, right? Stigmatizing language can show up outside of the confines of our working relationship or therapeutic relationship. And maybe it is still a barrier. We would love to hear. So I see Melissa sharing language that shuts down an open and helpful conversation. Let me see if I can get myself
Makes
here.
assumptions, yep.
Makes the client feel bad about using. The drug use is wrong, and so that's stigmatizing. Thank you, Paige. Again, Mihan, yeah, perpetuates negative perceptions. Gia is sharing judgments and pathologizing language. You're not capable, you're not smart, you always fail. The word addict, Gail is sharing, it can scare people away. Thank you, Robbie. Again, using the word drug addict. Thank you, Penny. Michelle is echoing that. Is the opposite of first person language. Thank you, Carissa. Absolutely. Using dirty versus clean. Thank you, Myra. It's blaming folks. Beth is sharing with us. Thank you, Beth. Don't use and drive. Candace, user, Michelle, shaming, right? It's making us think that the person is weak or lazy or dirty. Some people are born with a gold spoon in their mouth. It lowers the client's self-perception, right? And ability to feel that they can tap into their self-efficacy. It is your problem. You should know better. It's a barrier. It's those people. It is shaming. Thank you. Yeah. And so it creates a barrier, right? Because as Joe was saying, it doesn't create a safe space for people to come as they are, which is another belief and another practice of harm reduction, right? We welcome people as they are with no expectation that they need to change or should change to be treated as people, right? We believe that human beings should be treated with the same kindness, love, gentleness, care, affection, and connection that we offer other people that don't use drugs, right? Or other people that engage in other behaviors, that the behavior should not dictate how we see that human being, right? Because it limits us. Then we only see the use and we don't see this person is an amazing painter, or I did not know that they were a great cook, or this person is a whiz at mechanics, or an incredible electrician, or this person knows how to tap dance, and gosh darn it, I want to tap dance too, and I hadn't had the chance to learn, and I have good jealousy, right? And so it's thinking about people as more than their behaviors. And so stigma, if we think about stigma, or the way that we like to think about stigma, and here we have an image that shows, I don't know how to say that in English, so I would say, like, my translation was in Spanish, but it's almost like it's a diagram, right? And it has almost looks like a family tree, like that we use in oh my god, when we ecology, when we I can't believe I'm saying this. Yes, and the social work, sometimes you do the family, oh my god, there's a name for that, where you see the relationships and if they are good or if they're broken and why, and who was there and who wasn't. You all know what I'm talking about, and you probably can find the word and type it in the chat box for me, because I can't remember. I used to do so many of those when I was doing my degree. Yes, the genogram. Thank you, Beth. I was thinking the Enneagram, which is a whole different ball of wax. It's very different to that. The genogram. Gracias. El genograma. Dios mío. And so it looks kind of like that. It's the genogram of stigma. Right. And so when we think here, stigma starts with ideas, stereotypes, things that come to our head. We start believing or thinking, wow, we start thinking people with substance use disorders, people who engage in sex work, people who have been diagnosed with a behavioral mental health condition are incapable, fragile, dangerous, and cannot recover. Right. So we start thinking that. And then from our head, it moves to our heart, right? And then we start feeling that and believing it, right? And we start operating from a place of prejudice, right? We start saying things such as, oh, those folks are scary, they're shameful, they're less than. I don't want them near my building. I don't want them studying with my kids. I don't want that residential treatment program in my community, right? And then that leads into discrimination actions. From thinking about it and from feeling it, then I start doing things such as creating opposition letters, right? Going into public hearing when they have the public hearings for, to approve things in the community, when you have local community, oh my God, not the center or the house, but, can't think of it in English either, escaping me, but when they get together to decide if we're going to have the community operate this halfway house or this treatment center, we go in and we have organized to fight it. Those are actions, right? And they can be social and structural. So we don't want people to be our coworkers. We don't want them, yes, NIMBY town meetings. Thank you, Michelle. Thank you for helping me. I was escaping my mind in English. We don't want them to marry to our family. I don't want their kids playing with my kids. And then there's structural issues that we see. And I'm sure you see a lot of these in your practice, or you have clients or participants or patients that maybe have shared some of these too, right? Folks that are not hired or are not supported when they're hired. There's no recovery education around how to best support people that are employed that have past or present lived experience. Health insurance doesn't provide equal coverage. And I'll give you an example. National Harm Reduction Coalition, 6 years ago, we had a new ED. Her name is Monique Tula. She retired. And at the time she was coming in, she started revising our health insurance policy. And she realized that our health insurance policy at the time did not cover medication for opioid use disorder. It didn't cover methadone or access to buprenorphine, none of those things. And so folks in our organization, the Harm Reduction Coalition at the time, that were people who used drugs that were also in recovery and from opioids, and were using MAT or MAOUD to navigate the recovery, had to pay out of pocket for that medication. And so we looked at that and said, oh my God, it is a structural barrier, it's discriminatory. We're asking people to disclose something that they shouldn't have to disclose, because this should be covered for everybody. So it's just accessible. You don't need to name it. You don't need to ask for reimbursement. It just happens. And so we changed our healthcare policy to cover and include that. And so it was a good reminder to us that we cannot take these things for granted, right? That even if we're not consciously trying to stigmatize something, sometimes our policies and practices can and will. And that's why that constant reflection about what we're doing and how we're doing it is so important. Because, when we think of stigma, it is a social process that does reinforce those relationships of power and control. And it would lead to a status loss and discrimination for the person who's stigmatized, right? So we start perceiving those folks that experience stigma as less than, as not worthy, as not good. And then we internalize that, and then we don't ask for support. We don't ask for help. We don't engage with people in conversation about our substance use and what it means to us, and what are the things that we may like to shift and change about it in terms of relationship to drugs. Another piece that I think is important for us to explore before we go into the conversation that Joe's going to lead us in a second has to do with the functions of stigma, right? Understanding why stigma exists, right? It exists because it seeks to keep people out, but making differences be dangerous, right? But making difference be bad. It seeks to keep people away from spaces, from communities, from services, and ultimately it seeks to keep people out by discrimination, right? So stigma ultimately to me is one of the most pernicious things that people can experience. It's harmful, it's dangerous, it can lead to death because it leads to isolation, and it leads to shame and to dehumanization, right? And there's so many other things happening in the world that people have to fight on a day-to-day basis, that if you add stigma to that, it just can compound in such a way that it can make it really hard for people to move through the world in a way that feels safe for them. I think this is mine, Joe. I think it's mine.
Yes,
no, it's
yes,
yours.
yes.
It's mine.
No,
yes.
it's yours. Yes.
Well, it's ours. It's all of us.
Ours,
here.
right.
Yes. So as we're thinking of stigma and we're thinking of difference, danger, and discrimination, I want you to look at this slide and think about the ways in which those things can show up here, when we think of people who use drugs, right? We think about people who use drugs, and it is important also for us to look at the intersections of people's identities, right? I may be someone who uses drugs and I can show up somewhere, and because I don't present, because my appearance is not the appearance of someone that we expect uses drugs, because I appear stable and because I present in a certain way, the treatment that I will receive can be certainly different than the treatment other people may experience because they show up or appear in a way that we stereotypically think is the way that people that use drugs look and show up, right? So thinking about what that means for people, thinking about the role that ethnicity and race can play into their experience as people who use drugs, as well as gender and sexual orientation. I think we talked a little bit about that when we were looking at risk set setting or drug set setting, right? As well. That person's health status. What are some of the things that are coming into play that intersect with that person's substance use, right? Is this person navigating also mental health conditions or physical health conditions that impact their use and vice versa, right? And their ability to seek and access care because of that. How are the drugs consumed? That is another huge thing. I remember working in a drop-in center in Holyoke many years ago and hearing folks have this conversation. I'll say it in the language that they said it. You know, they would be in the drop-in center and somebody would say, well, at least I'm not shooting up and nutting off all the time. And then the other one would turn around and say, at least I'm not a crackhead and smoking crack all day and trying to look for that money. And then the other one would say, well, I'm not this. And I'm thinking, you all. It's like, we're all here and we all, when people see us, they see people who use drugs. So, you know what I mean? Like, you know, it's internalized oppression, right? It's internalized stigma. So there's this notion that there's a hierarchy around substance use and ways of consuming drugs, snorting it, you know, cocaine, the 80s Wall Street seems chic and great, right? And then you have, or like, you know, disco, oh my God, that Studio 54, and then you have crack cocaine, and then you have this other image. And that's socially constructed, right, for a reason, because it perpetuates racism and the war on drugs in the prison industrial complex. And so thinking about whether drugs are prescribed or street also, it's another hierarchy there, and which drugs people are using, right? So it's thinking about all of these things and how they play out in that person's relationship to themselves and to the society at large and how they show up to us, right? Because I may disclose that I have issues with Ritalin or Adderall, right? Because I feel that's safer than to say that I'm using meth, although both substances are pretty much the same in terms of their chemical composition, right? The only difference is what? Adderall is prescribed by a doctor, so it has legitimacy in that way. So misuse, right? I can say I'm misusing Adderall versus saying I am shooting up or, you know, ingesting methamphetamine because I need to stay up because I need to go to my third job because I have to provide for my family and that's the only thing that keeps me up, right? Or I need to dance all night. Because, you know, if I don't dance all night, I don't make enough money to pay for my rent and pay for things that I need to pay. And so the perception around which drugs and how they're used, whether prescribed or not, also impact the language and labels that we use, right? Chemical dependency versus misuse versus addictions, et cetera.
So what I would also say, Tanagra, is so I have found this with a few people that I've worked with where they started, you know, using pain medication, and then because of expense and that sort of thing, started snorting heroin, and then they would say, "But I would never shoot it." But then, for various reasons, various circumstances, they begin to shoot it. And now they have an added stigma to themselves that they have become the person that they were sort of trying not to be. And so then you're also dealing with that sense of shame that they're struggling with. So we think about this notion of all these, as Tanagra pointed to, all this kind of stigmatizing language that is used that really, and I think I mentioned this in the previous webinar, when we think about, you know, and language matters, and we'll talk about that a little bit more, but what it does when we, so I work a lot with people around anger, and I talk to people about when they referred, even if they're thinking a person in front of them is an asshole or a stupid idiot or that sort of thing, what you're doing is you're making it less you're making them less than. And so it makes it easier to be aggressive towards that person because you're diminishing them. And I think that's what happens when we use stigmatizing language. Next slide. So maybe, again, getting some feedback from people in the chat. What do people think is person first language? And why do people think it's important that person first language be used in dismantling stigma? Person using drugs, a person who uses X drug. It recognizes the person as human first. Yes, a person who. Identity first, not the challenge. A person is more than their problems or labels. Great. Respect. Yes. Identity first, they are not the substance. Great. Person is more than their diagnoses. Correct. Absolutely. Bill. All right.
I have a question
yes.
for Jude. I actually had a thought and I wanted to see if I could ask you a question or maybe ask the group, right? I think that, and this is something that I've come to tension in the past with in my own practice, which is I want to use person first language with folks and I really want to embody and like uplift their humanity. And I've had participants that use the same terms that we're talking about. Oh, I'm a dope fiend or a crackhead or I'm an addict. And they use that language to refer to themselves and their experience in the world. And sometimes I have found it challenging to figure out a way to sort of not shame them for using that language, but also to try to explain that although it's safe for me to use that language with me, that outside in the world, it can have different connotations and that people cannot translate or interpret what the person is saying, and that can continue to perpetuate stigma. And I wonder if you can speak to that or other folks here could speak to that. Like, how do we navigate that when folks are using that language, but we also want to sort of create space for reflection around when it's safe or not safe to use it, right? And how it feel empowering to them. And we don't want to take away that from people.
So actually, Tanagra, that nicely segues. I'm going to talk a bit about that in the next slide. And a couple of people have their own thoughts, so we can share those. So language matters. So a person with a substance use disorder say this instead of abuser addict. Use morally neutral terms like resumed or experienced a recurrence of symptoms rather than lapse, relapse, slip. Use specific terms such as medication or non-medically used substance versus and not drug. Use proper medical terms for positive and negative results for substance use, not clean and dirty. So that, first of all, personally, I still, more so with the use of the term lapse, relapse, and slip, I still find myself doing that. And so it's something that it's a work in progress for me to be more conscious of resumed or reoccurrence versus lapse, relapse, slip. So Tanagra, to your question, I think the other part of it is in 12-step programs, you start by saying, hi, I'm Joe, I'm an addict, I'm an alcoholic. So using those labels. So in that sort of culture, there is that terminology. And I'm very careful about that's where it is. They use that language, but exploring, I think to your point, but exploring why that may be helpful to see themselves that way, but also consider other alternatives to using that language. And then to your point about educating sometimes that outside of maybe 12-step, to use that language is going to give people a certain impression. And so maybe using other terminology is going to be more beneficial. So that would be my thought. And I'm sure other people here have some ideas.
Yeah, there's a lot of good stuff happening in the chat box in regards to this. And if it's okay, maybe I can let some
Yes.
that folks share.
Yep.
Do you measure or know the degree of risk according to risk setting and self-stigmatization? At first, I will use their language. At some point when the trust has been built, we can revisit language and ask them about their perspective. Thank you so much for that, Jamie. Everyone has different paths, as Robbie is sharing in the chat. Carrie is sharing, sometimes you need to meet the individual where they're at. We can educate, but people ultimately use the language that feels comfortable to them. Myra is sharing, advising folks that the stigma language can interfere with their own recovery by keeping themselves in this space of feeling that they're less than. Olivia is sharing that they ask folks why they choose to use that language about themselves, and ask if it's okay if I don't call them by those identifiers using different language. I will use their language to show that I agree. And Reed Gordon is sharing, Mary is sharing that self-stigmatizing language can be determinative versus choices, right? So I will act according to the way that I see and think of myself. And Carissa is sharing that, yes, I definitely use that language about myself. I share with people what first person is and how identifying themselves with stigmatizing language feeds the stigma about all people. I encourage people to speak about themselves with mercy and grace. And finally, we have Paige sharing, you have to meet the person where they're at. Sometimes 12-step programs are really in line with strengths, perspective, and harm reduction. So absolutely. Thank you, folks.
Thank you
for sharing those thoughts, and for moving us to this next slide.
So again, this was a question we asked in the previous webinar, but just helpful to kind of reinforce again very quickly, what are ways that stigma show up in your work and practice, or if people feel comfortable, how stigma still may impact on how you work with people, because again, I think that's important.
So many hierarchies.
Yeah. People are reluctant to get into treatment, and stigma may be a big barrier to that. Thank you, Rich.
Yeah, Paige is sharing, people really do have these morals. They set themselves of what is right and wrong in drug use. People
deny that they have a problem, right? And
Lisa's sharing, I think Lisa's point is really important too, right? That Lisa's work with social workers and nurses, when they are overburdened with too much work, they're more apt to use stigmatizing language of others. Absolutely. Burnout,
yeah,
compassion, fatigue.
Good point. Yep. People don't, Paige, people don't realize that it's a mental health issue in and of itself.
Betsy's echoing that the language from the previous slide is getting used a lot in the workplace. MSW interns who bring their own preconceived ideas about addicts and addiction. Myra's sharing. Watching my own assumptions and language. Yes, Mary. Part of the harm reduction practice is that constant self-reflection, right? And really looking at ourselves and how we show up and what are the things that come up for us. Because we may have personal lived history, right? About our own selves or others around us that we bring to the work, and we bring who we are, right? And that it's there and can come out when we're working with folks. Oh, wow. Anne is sharing a really good one, Joe, which is the lack of telehealth for MAT, or requiring people to commute long distances to get their prescriptions can be a huge challenge. And Olivia has a great one. It makes me think of you. Assuming folks want help or see it as a challenge, you know, you always say that we can't assume that. I have to be mindful to meet people where they're at.
And then also a shame and stigma comes up with obese people, especially, right?
That intersection.
Yeah.
Stigma can show up by avoiding the client. Yes, that is so true. I have experienced that myself. Seeing drug use as a moral failing, Megan is sharing with us. Carrie's sharing that I work in medical social work, specifically liver transplant. We see stigma attached to those with SUD-related liver disease versus sick folks with other reasons. Patients struggle with treatment if their illness is from substance use, yes, or they can be passed up for, the same for the endocarditis, right? For sometimes folks need support with like the valves or their heart or transplants, and they can be passed up if they are someone who uses drugs, right? Because it's perceived that, you know, they don't really want to be healthy or get the health that they need. This is great. Thank you, everyone.
All right, thank you.
So now we're going to continue to give this some food for thought, you know, in terms of language, labels, attitudes, and behaviors, right? Language forms the way that we view ourselves and we view the world, right? So I want to think with you all, and hopefully we'll get more of your brilliancy in the chat box. If you can share with us specific language, labels, and attitudes and behaviors you observe from providers. And I think you started to name some of those in the chat that may be stigmatizing of people who use drugs. And this can be overt things and not so overt things, things that seem more like micro stigmatizations, but are just as impactful to people when they experience them. Ways in which you had seen participants, patients, humans respond, react, and feel about those experiences. And ultimately, how can you respond and communicate more effectively as a provider? How can you remain aware of using affirming, empowering, and non-stigmatizing language? And I know that you've all started sort of to think about that and name it in the chat box, but we would love to hear more. And I see here that some of the things that have come up for folks is family giving up on them, having to defend yourself or your substance use, providers talking about how they think Suboxone and methadone is bad, outright stigmatization. Providers shouldn't be talking about their views on that. Thank you, Paige. Robbie sharing that it is a weakness, right? People perceive it as a weakness, as someone said earlier, as a moral failing. What are other things that come up? Yes, stigma against parents with DCSF and DSS involvement. Absolutely, Anne, thank you. Oh, thank you. Always, robando cámara. Untruthful and deceitful, yes. Providers referring to people as frequent flyers, absolutely, yes. And how demeaning and hard that can be to hear. Yes, and the weakness can become people's strength. Malingering in medical records, difficult, non-compliant, right? Working with addicts is a waste of resources. Right? So all of, yes, you know, so all of those things come up. We lose faith in people, right? As Gail is saying. And so if I am referring someone, I'm sharing el expediente, you know, the record, the medical record, and I have those words there. What am I telling you as a provider who's receiving this record, right? Can we read between the lines and see the words and what they mean, right? Or are we going to think, oh, this is a non-compliant person, this is a difficult person, this is a frequent flyer, so I'm not even going to care about them. I'm not going to waste my time because they don't really care for themselves. You know, they're demanding and needy, right? And so thinking about those things in terms of how do we also can be advocates, right? To support people who use drugs and to support our clients and our patients. Yes, Melissa, that also I wanted to say in my practice, that point of the way that treatment notes are written is really important. Our notes, I don't know, in Puerto Rico, for example, your notes can be, they can ask you if there's a court case and it involves that person, they can ask you to give out your medical notes. We've had participants that I work with that were embroiled in, oh my God, not paternity, but like custody cases. Custody. And we had to be really mindful of what we wrote because they would use that against the person to take their kids away from them. And so that piece of how do we write things so that they are explicit enough for another coworker to understand, but also protect the patient is super important. Yeah, thank you for naming that. I think that that is really, really important. And I am going to pass it now to Joe to walk us through this scenario and get your feedback and your thoughts on it.
So I think I came to the realization that I think we all need to be, there is the term being trauma informed, but I also think we need to be substance use addiction informed. And this came up in a situation from a number of years ago. So this scenario, it was obviously a real situation where I was working with this man in his mid-30s around PTSD and anger issues. And about 6 months into treatment, he had disclosed a history of misuse of Percocets and other prescription painkillers. Now, when I first met with him, and I'll get into that in a moment, I always ask people when I first meet with them about their substance use history, and he denied any issues around painkillers. And when he shared it, he was quite apologetic about not sharing it sooner. Because I said, I had asked you these questions, what was going on? And about a year or so before we met, he had been seeing a therapist and who he felt connected to, and he disclosed his problematic use of painkillers. And according to my client, she told him he had to immediately go into an inpatient program before she would continue to work with him. So when whether it's stigma or just a lack of understanding, no sort of assessment around, did he really need an inpatient program, or having it conditional on his continuing to see her. I just think it's, I think I understand there may have been probably some anxiety on her part, but it just sort of, so he ended up dropping out of treatment because he had no interest in going to an inpatient program. And so he shared that he had been reluctant to tell me because we had developed a therapeutic alliance, and he was fearful that I would treat him in the same way, that I would find out about this and say, okay, I can't work with you anymore, so you're going to have to find someone else. And so I just think it was just a real life sort of situation for me. And as you think about your own work, particularly those of you here who are participating who may not feel completely comfortable working with people with substance use problems, to really sort of think about not engaging or with a person in that way, to kind of cut them loose, because it obviously took him some time to be able to share with that woman, the therapist, sort of what he was struggling with. So I don't know if anybody has any thoughts about sort of that situation.
I think while we wait for folks to chat in the chat box their thoughts around this, Joe, like when you share this with me, it made me really sad for this human, because, I felt, wow, how much potential harms they had to experience, right, before they were able to feel safe. And also how hard must have been for that person to see themselves as a full human being, as you were able to see him,
right.
And give him the opportunity to be able to think about the intersection or their interaction with the substance in the context of their life, right? But not having that opportunity like that. That made me really sad when I heard you say that. I was like, wow, this is dangerous, right? It puts this person at more risk. Right.
Yeah, and then in terms of sort of people sharing, so many assumptions made in that situation. Cheryl, thank you. Sam, this scenario probably occurs much more often than we think. Yes, it to even think that it occurs with that frequency really is concerning. Reminds me of decades ago, therapists told not to work with someone until they became clean and sober. Yes, absolutely, Sherry. It sounds familiar. Was this a past practice? No, it was in my current private practice. So I've been in private practice for a while. I often feel that people don't trust or feel safe sharing difficult stuff, especially people with trauma. Marijuana use very common. I'm assuming that that may be something that people may not want to share as well. And yes, I would join the person in saying how hard it must be to have told me. Absolutely. Yes, I had a past supervisor suggest that this was the only way. Yeah. Just a lot of bad information out there. Classic case of therapist agenda versus patient's needs. So, you know, I want to show a little bit of potential empathy towards this therapist that, again, perhaps her anxiety and maybe some other history from her own personal background or other clients may have, but it interfered with providing good treatment for this individual. All right, so why don't we thank you all for your feedback. So points to consider when taking a history of alcohol, drug use. And again, this is for individuals who may not be particularly as comfortable dealing with these issues. So I do it with everyone that comes, whether they've identified or the referral was identified maybe, is I just ask it as part of a lifestyle. You know, question what's their diet, what's their exercise, tobacco use, caffeine use, you know, that sort of thing, and normalize and be transparent. And again, if people sort of might bristle a little bit, you know, just to reassure people, I ask everyone because it impacts on their overall health. And so being normalized and transparent about it, but asking permission. Would it be okay if I asked you some questions about your use of alcohol and other drugs, and giving them the option? If you don't feel comfortable, that's okay. And it may be once you have a stronger therapeutic alliance, you may return to it. You know, how questions are asked is important. And then if you have a sense that a person may use a substance or substances in an ongoing way, just to, have you ever used alcohol or other drugs to relieve emotional distress such as sadness, anger, depression, anxiety? I think it's a pretty straightforward, and I think it's as non-judgmental as possible in terms of that can often be a function of substances. So I think that's a good question to ask as well.
And I think also, you know, building up on creating safety in terms of the way that we approach the client or the patient. There's other things that we can do, right? Or think about when we're trying to create that safety, right? And the first question we can ask ourselves is, why would creating a safe environment be helpful when trying to engage a client in a potential conversation about substance use? And I think many of you have already named it, right? That being safe means that I feel like I will be heard and seen and treated with dignity and respect as a person, right? And so why would that safe environment be helpful when we're trying to ask someone these questions, right? And get them to disclose or think through them with us? We can ask ourselves, what does safety look like for us? Or ask that person too, right? I would ask the participant, what would safety look like for you? What do you need from me, right? And that'll be different depending on who the person is. And finally, the question that we ask ourselves too, and that I ask myself all the time when I'm working with humans is, how would I know if the client feels truly safe? What would be some cues you would look for? And I would love for you all to share some of those cues with us in the chat box. How do you know at the end of the day, when you're working with a participant, a patient, or a client, that they feel truly safe with you? What would be the cues you would look for? And I see Karen is sharing that they speak freely. Dulene is sharing, I hope I'm pronouncing your name correctly, cooperative and engaging. Lisa's sharing body language. We could also ask, what can I do, the therapist, to make it safer for you in here? I love that, Nancy. Thank you. Jane is sharing body language as a cue that this is working. Folks are engaging and trusting. Sam is sharing. Paige is sharing that they actually do ask for help. We see sincerity. We feel that the person is authentically sharing. Thank you, Billy. Melissa is sharing that they can express frustration about systems or about me. Yes, that would be mine, Melissa, too. That's when I know that therapeutic alliance and safety is there. C. White is sharing progress and being honest with the good moments and the bad moments. Rich is sharing that people are smiling, they're engaging. Bill is sharing that the clients seek me out on the unit, that they want to connect with me. If they disclose personal information, also it's important. The client is open about their situation. There's eye contact, right? They ask questions, you know, are you feeling comfortable with my style? That's something we can ask. What else can I do to make you most comfortable? I love that. Thank you, Beth. Jamie's sharing, I asked them what went well in their last session and what would like to see change to meet their needs. So that constant self-evaluation and giving them opportunity and participation to own that process with you. They come to our appointments, yes, Tracy, and they want to show up and they're excited to show up, revealing their sense of humor or personal stories. I love that, Megan. Thank you so much. Thank you, folks. These are great. Mihan is echoing the importance of people feeling that they can express that frustration, because it takes a lot of trust and safety to do that after the relationship has been formed. Absolutely. Thank you all. Those are all great cues that we can look out for to know that what we're doing, that we're actually truly creating safety for people. And I just want to share some other elements that we can, you know, keep in mind to create a safe and stigma-free space. Visibly display literature or materials related to harm reduction services that are there for everybody, right? It can be safer sex, safer use, how to connect to your local harm reduction program, you know, or any like thing like that. Visuals and images that transmit to participants that they are welcome. I went once to do a training in Indiana at the Indiana Recovery Alliance office, and they had a big, one of those big whiteboards, and they said, "Hi, I'm glad you're here. You're welcome. You're loved." And that was for everybody, right? And it let people know, you know, I am someone who's coming here maybe for the first time, and I have such fear of accessing these services. And it immediately, you could sense when people walked in how they relaxed, right? So things that let me know that I'm welcome: race and gender expression, sexual orientation, social use status, people that look like me, that may sound like me, that may hang out with folks like me, right? That stuff make me feel welcome. And we want to convey an understanding that abstinence is not the only goal, right? And by having these things in display and having that space for conversation, it's another way of letting that, hopefully that person, Joe, that man that you were working with, if we have that person come to us again, that they can be safe in this space, with us. So now I'm going to pass it to Joe.
Okay. Thank you, Tanagra. Again, so just for the sake of time, but please feel free to share your answers to this question. So what could be some questions you could ask someone to begin building trust and rapport, especially around sort of issues related to substance use? So welcoming people's comments there. And then just to sort of, next slide, please, Tanagra. So here are some open, you know, really important, I think most of you know this, asking open-ended questions rather than do you, you know, what do you like about drinking alcohol, or fill in whatever about that. I think people sort of, sometimes people, and I think that conveys again, curiosity and non-judgment, that you're asking a very straightforward question and appreciating that people use for different reasons, and that you're not going to you're not going to be judgmental about why the person may be using. How do you think it will be different if you tell your partner your Hep C status, if there's an issue around disclosing it to somebody? Tell me about your cocaine use. So again, people have, you know, we talk about narratives. People have narratives about their substance use. So we want to get into that. How can I support you? You know, and not coming with any preconceived notions. And again, if we think about this in the context of the stages of change and motivational interviewing, and then so one of the questions I always ask people is, have they been in therapy before? What was their experience? If it was good, why was it good? If it was bad, why was it bad? Because that gives me some insight into how best to approach it. But is there anything I could do differently from previous therapists when it comes to discussing your substance use? So again, all of these are questions to really try to get into a conversation about a person's potential substance use issues. And so, okay, and I'm going to turn it back to Tanagra.
Yeah, as we're wrapping up, it's also a reminder to come to this perspective from a healing center approach. A lot of times stigma makes us think that people are broken, that people are sick, that people can't find their way back to themselves and reconnect with who they are and embody that person. And so when we think of harm reduction and we think of healing center approaches to the way that we view our work, we can think of these principles of building safety, building a space that is transparent and that people feel that we're trustworthy, thinking about how to engage participants through a framework of collaboration and mutuality. You are co-creating this with me. This is your process. I'm here to support you. I am willing to take your lead. I want to take your lead. I want us to learn from each other by giving people empowerment, voice, and choice in what they decide to bring to therapy and how they want to approach it, going at the speed of trust of the participant and understanding the impact of cultural and historical issues, right, for people. Many cultures like mine, therapy is perceived as something bad. Only, I will say this as a Puerto Rican person, únicamente la gente que creen que están loca, only people that are not well in the head, and this is how we think about it, go to therapy. And so there's a lot of shame around that. And so how do we, it takes a lot, as someone said in the chat box, a lot of strength for that person to come back to Joe and trust the process again. And that's such a gift. And we want to make sure that we protect that gift, right? By thinking about the cultural, historical issues that can come up and how do we connect that person to peer support? So someone else said something in the chat box that I want to uplift. We don't have to know it all. Do I have to be an addictions expert? We're going to ask you in a second. One thing is, you know what? You can connect people to harm reduction programs. You can connect people to other peer support so that they can build upon the work that you are doing, right? You are doing really important work. And your work is to support that person and what they need to work in at that moment. And if they're open to it and you feel that you have those connections and they're not connected to harm reduction programs and they would like to be, knowing who to call and where to call is super important, right? Because that could be another pathway to connecting someone to a space that sees and cares for them and welcomes them. Now I'm going to pass it to Joe because we want to hear what you think.
Yes, so I think to this point, and somebody, I think it was Anne, talked about, so this balance about being, you know, somebody that feels comfortable in working with people who may struggle with substance use issues, but also the ethics of our competency. And so we have to certainly balance that. And to Tanagra's point about having, you know, potentially referring somebody to a harm reduction program and being able to consult with other clinicians who might have more experience in what to do with that individual. And absolutely, it is a balance. I guess my thought is that hopefully people are mindful not to sort of engage in the experience of my client's experience with that therapist who just basically cut them off, and really to be conscious of not doing that and having a more full conversation. But to questions or things that we've already talked about is what do you need from me? How can I be of support? And don't make assumptions, which I think has also come up in discussions. So one quick question before we wrap up, is there one thing you are taking back to your practice based on anything that Tanagra and I have shared in this webinar.
I see some things coming on. I think we may have a couple of minutes to share the video if we want to share it. So I'm going to stop sharing my screen so I can cue that up, because, you know, I want to make sure. And I think the slides, I don't think I know, it's that the slides will be shared with you all too. So you'll have access to those.
Right, so use of more sensitive language, be more mindful of the language I use. Again, reminder of the importance of language. That's all great. Yes, thank you, thank you. More self-awareness, absolutely. I think just, and I could go into detail about all my therapy failures, and a big piece of it was my own lack of self-awareness and what was going on for me. So I don't think I can emphasize that enough. So
I love Nancy. I don't need to be an expert. Yes, I love that. Yeah. Thank you. So if it's okay with folks, I want to share this beautiful video that was produced by the amazing folks at RIZE. And I just couldn't close today without showing it to you, because I think it's really powerful and moving, and also speaks to what we've been sharing today. So I'm going to play it. Let me see if I can make my screen big. Will that work? Yeah. Okay. Here we go.
See, for social workers in combating the overdose crisis has a lot to do with relationships and communicating with people about the dignity and worth of people in our communities. There isn't a single community that I can think of that doesn't have people who use drugs that live there. And a lot of the times we just shun these folks, or we pretend that they don't exist. We don't offer services, compassion, or support. So for social workers, our goal is to really be thinking about the worth of every individual, the fact that we all deserve support. We all deserve human relationships. And for social workers, our goal really is to be relational and to develop those relationships, build rapport, build trust with people who have long trauma histories, or maybe don't have social supports, have had many negative relationships and experiences related to drug use and beyond. So for us, we build that rapport, we create that relationship with folks, and then we're able to bridge that gap between people who use drugs, the communities that they live in, the services that they're trying to access, and the supports that they have. We're uniquely positioned in social work to be able to do not only that relational clinical work, but also the macro level work, the advocacy work, the policy work. We're change agents. So part of what we need to bring to the table is, what's this person's lived experience? How do we highlight this person's strengths, their worth, their resilience? And how do we translate that to our politicians, to our people who hold power in our communities, to help them to understand the power behind making sure everyone has a place at the table, and really changing the way that we treat people who use drugs and the services that are available for them.
Bravo. Thank you all. Just want to thank you for attending our workshop, and Tanagra and I have left our email addresses. Feel free if any questions or thoughts you may have. And Tanagra, I don't know if you want to quickly say something, and then we'll turn it over to Chris Belli to give the code for your CEUs. Oop. I think she may have frozen. Oh dear. Oh well.
I'm here. I'm back. Sorry. It's my internet. Puerto Rico internet. It's still unstable. Thank you. I am so proud to be a social worker and to be in community with all of you, and to be part of this amazing siblinghood. Thank you, thank you, thank you. And thank you for the work that you do. I appreciate you.
Thank you all. Yes, absolutely.